Hi, everyone. Welcome, welcome, welcome to another edition of What's Up, Doc. We have an incredibly unique vascular surgeon with us today. I am so excited to talk to her and share her with all of you. It's Dr. Lily Johnston. She is out of Scripps in Southern California in San Diego. And she is not only a vascular surgeon, but she also separately specializes in metabolic health. What if all doctors, what if all surgeons, what if all interventionalists, everyone involved in vascular actually sat down and talked about metabolic health with you? How much more committed would you be to creating the change that everyone wants to see, which is those critical lifestyle changes? And the way in which I think that they would do that in meeting with someone like Dr. Johnston is if they could tell you what is driving your personal issues, what's leading to your plaque buildup in your body that may be different from someone else. So excited for this conversation. Dr. Johnston, thank you so much for being here. Would you mind just sharing, a little bit about your background? You became a vascular surgeon. Where in your journey did you actually get excited about metabolic health and following the path of functional medicine as well?
Absolutely. Thank you so much, Kim, for having me. I'm excited to be here. Your passion comes through loud and clear, and I'm grateful to have this opportunity to chat with you and share in this journey. I finished my training in the middle of the pandemic, and we had a little extra time, and so I began listening to podcasts and chatting with my mom, who's also a physician, and we started talking about intermittent fasting was how the conversation started. And I got really interested in that because there was a great paper in the New England Journal of Medicine, which is a very prominent medical journal, and it talked about all of these different cellular and clinical impacts that people noticed, through intermittent fasting. And that took me down a whole rabbit hole of metabolism into the role of ketones as an energy supply. And then I discovered that people were using therapeutic carbohydrate reduction as a treatment strategy for many, many things. Very specifically, diabetes and dysglycemic disorders, but also things as wide-ranging as schizophrenia and nerve pain and all kinds of really interesting issues. And so I started learning more about this, and it very much started as a personal journey. I wanted to know about this for my own health and well-being. And after I kind of made some changes to my own lifestyle, I began to wonder, what about my patients? Would this benefit my patients? And, everybody talks about higher fat diets, and what about the cholesterol and what about the plaque? And I thought, wow, this is a fascinating area. And at that point, I didn't know. I was just investigating and learning and getting curious, but I hadn't really figured out what that meant for my medical practice. I was still focused on just the vascular surgical piece and trying to understand how to care for patients. My first job out of training was with a large multi-specialty group in Northern California. I was in the Sacramento area for a couple of years. And as part of that practice, we did all of the lower limb amputations for that group, including patients who did not have problems with their blood vessels, but who just had such severe infections or bone disorders that the leg was no longer salvageable. And I was seeing an enormous number of patients with diabetes that was out of control. And when I talked to those patients, it was clear to me that part of the problem was the education that they were not receiving about how to really manage that. I mean, they were, you know, being told what the guidelines are. And so it's no shade to the dietitians or the educators who were trying to help. They were delivering, sort of what is considered standard recommendations, but the patients were getting worse and worse and worse, and it was resulting in an astonishing amount of limb loss. And I was just devastated, right? This was not me really helping and healing people. I mean, sure, I treated an acute problem that was life-threatening, and okay, that's nice, but nobody wants to go into medicine to do amputations and take people's legs. Like, you want to go in to help people and prevent that from ever happening. And it just became so clear to me that this was a huge unmet need, that patients were
Yes.
not receiving as much education and information as they could, and they were hungry for it. It's not like these were patients that were not taking care of themselves or, being non-compliant. These were people who were trying. They were really absolutely following their instructions to the letter and kept getting worse and didn't understand why. And it was just devastating. So that's really when I jumped on this bandwagon of what can I do when I encounter these patients in my practice to help them not get here, right? And then it became a much more intricate exploration of what really causes plaque and what causes diabetes and where do these metabolic disorders come from and how should we manage them? Should the solution be the same for everybody, or should we customize this? Can we learn other things? Where do the guidelines fall short? And then in 2023, I decided to move back to Southern California, which is where my parents are. And I didn't have a full-time job here, so I started doing locum tenens or travel doctoring, but it gave me a little extra time. And with that extra time came even more exploration and certification in nutrition pathways and deep dives into hormone therapy and weight reduction and treatment of obesity and a bunch of other sort of related components, deep dive into lipids, lipid management, and what's the role of medication and supplements in that. So after all of this, and I'll quit talking here in a minute, I promise, but after all of this, I have come to
Fascinating.
believe that the formation of plaque in arteries is a very multifactorial process, right? And I think most people in the cardiology space would agree. There are lots of things that can cause plaque to form, and then there are lots of things that contribute to the ongoing disease process. And so it's very important that we try to understand what the root cause is for each particular patient who comes to see us, right? For some patients, it's a metabolic dysfunction like insulin resistance or diabetes. For other patients, it's tobacco or nicotine products, other toxins that disrupt the endothelium and then must be healed. For some patients, it's an inherited disorder like familial hypercholesterolemia or LP little a, other kinds of maybe hyperhomocystinemia, right? There are a number of different things that can contribute to the formation and progression of plaque over time. And so the first step is figuring out if people have plaque. Believe it or not, for the number one killer of people in America, that's heart disease, we don't screen for it. We screen for breast cancer, we screen for colon cancer, but we have never come up with a screening pathway that meets all the public health epidemiology criteria for appropriate screening. So we don't do it. We could talk about screening versus early detection, but I did promise I would stop talking. So anyway, we will come back to that perhaps.
Actually
But
goes straight there. I find that absolutely fascinating. It's one of my biggest issues because still today, this is 2025, and we don't have an actual low cost screening for plaque in the coronary arteries. Yes, you can get a calcium score, it gives you an indication, but until you are presenting with angina for most people, not the new angina, which is fatigue when exerting, right? Some are doing that now, which is exciting. If they have a history of heart disease and possible age-related risk factors,
mhm.
but they're just not doing the additional methods because you have greater exposure, right, to radiation, and they're big things, like the PET scan or the CT angiogram or a 360
Right.
slice, and there's just no easy way to do it.
There's not. And so one of the issues about screening is that if you're going to screen everybody, right, the test has to be cost effective. We have to be able to intervene in an appropriate and timely fashion, and it has to be accessible. And so there are a lot of criteria for screening, and that's a very rigorous bar, which is appropriate. Here's what I'll say. We know that metabolic syndrome and metabolic dysfunction is an enormous risk factor for the development of cardiovascular disease. And perhaps in today's era, it's the leading cause of risk for that, right? In some series, it actually confers significant additional risk above and beyond smoking even, right? So diabetes is not just the new smoking, it's worse. So if we look at the US population and look at the criteria for metabolic syndrome. So high blood pressure, HDL, triglycerides, waist circumference, and all these things that contribute to the diagnosis of, and fasting glucose, to the diagnosis of metabolic syndrome. If you look at the percentage of America that has zero of those criteria, that is perfect metabolic health, it's about 10 to 12%. So if we just want to now talk about early detection for those patients who are at risk, we now have about 88% of the US population at risk based on our NHANES data with one or more diagnoses that contribute to metabolic syndrome. So that's 88% of the population. It's not screening, it's early detection because they are at risk. It's not everybody, but it's a huge swath. And we can talk about methods for early detection, right? Coronary calcium, as you mentioned, is one. Coronary angiogram is another. I personally like carotid intimal medial thickness or femoral medial intimal medial thickness because it can detect soft plaque without radiation, and it's nicer in a younger population that may not pop positive on a coronary calcium score. So
How
this is
does that
something
work?
sorry.
How does that work?
A CIMT. So it's
Yeah,
just like a carotid or a femoral
I
duplex where you
just
would
heard
look for
about it.
stenosis, except what
Yeah.
we're measuring is the thickness of the intima and the media, the two innermost layers of the vessel. And we also assess for the presence of plaque, but it's not necessarily a hemodynamically significant stenosis, which is usually 50% or greater, right, by velocity. We're looking just visually for the presence of plaque. And in our lab, that's a thickening greater than 1.3 millimeters. CIMT for sure has had some issues in terms of reproducibility and reliability in the past. And if you go through the literature on this, there's a reason that it's not commonly recommended. I think that it is possible to overcome those issues using very reliable methodology and a good lab. So CardioRisk is the lab that I use, and it is the only thing in medicine for which I have ever had to personally do a double-blind randomized test. Right, all of my board exams, those were pretty standard examinations. But for this, I had to go to Utah and scan 5 random people twice, and my results were blinded and tested against a sonographer of 20 years experience. And to be able to scan for CardioRisk, I had to have enough reliability and reproducibility in my own ultrasound to match their sonographer and meet up with all that. So I think it's possible with enough rigor to overcome the limitations of CIMT. However, you will find if you go look at the evidence that it's not necessarily a recommended test. However, in young patients, to evaluate progression of disease, to evaluate for soft or heterogeneous plaque that has not yet calcified, I think it's a great tool. So it's something I use in my practice in addition to calcium scanning and CCTA or coronary angiography.
So I'm guessing you're spending more than 5 minutes with each patient.
My initial visits for my metabolic practice are 2 hours, and my office staff knows I run long. Our follow-ups are an hour. And as I try to bring some of that into the Scripps system, it's not going to be quite that much, but I think we're going to try to start out with initial visits of an hour and follow-ups at half an hour, and we'll see how that goes. But no, it's not possible to do this in 5 minutes. It's just not. And the CIMTs take me about half an hour.
So it's one thing to actually have interest in it, study it, get all of the certifications, et cetera. But it's another thing to continue to stay motivated with it. And that had to have come with success in your practice. Can you bring us back to that moment with that one patient where you had this aha moment and you said, oh my God, this really works?
I think what's fascinating about metabolic disease is that people come in with kind of a they come in with a goal, right? And sometimes the goal is fat loss or weight loss. Sometimes the goal is, balancing my hormones. Sometimes it's heart attack and stroke prevention. But what I've discovered is that when you truly manage people's metabolic risk factors, and that includes everything from nutrition to exercise, to sleep, to stress
Mhm.
management, to medications and supplements. If you get all of that kind of dialed in for people, it's not so much that I can promise you I've prevented a heart attack. Like, there's no way for me to prove that in any given patient, right? I can't say that. But what I can say is that for the first time in my medical career, people come back and say, oh my gosh, I feel so much better. Like, thank you. I mean, I get that occasionally in the surgical practice, right? Occasionally somebody with terrible claudication or terrible rest pain does come back and says, gee, doc, thank you so much. But a lot of what we treat is asymptomatic, or the symptoms are not pain, but they had a stroke and they don't feel better after their carotid endarterectomy. They don't feel worse necessarily, but like they don't come back and say, "Gosh, thank you. I feel so much better. I'm ready to go out and conquer the world. And what I get out of my metabolic practice are patients who come back and feel amazing and they want to go exercise more and they want to continue their good nutrition habits and they want to, do more good in the world. And that is so rewarding that I can't give that up now for anything.
I love it. There are this is what the patients are talking about when they go online. There are all kinds of different social media groups that are, telling people to take statins, and other ones saying statins are evil, and some saying do procedures, and others procedures are evil. And then there's people who are, do you have homocysteine? And here's a whole group. And most of these groups are all run by patients, and it's almost like the blind leading to blind. And there are several groups where the patient becomes the expert because they're on their soapbox looking for affirmation for their own choices in care and based on their own experiences, which, as you know, that's not necessarily representative. And it can be harmful if there are other people with different experiences that don't typically relate. So we need more doctors really talking like you and doing what you're doing, to get the word out there and to start helping these patients in the office and addressing these concerns and not brushing them off, but just hitting them head on and not just saying, as we hear all the time, well, the studies show this and we're not even going to have this conversation. And the number one that we deal with on a daily basis, that it's back and forth. What do you think? Statins. Do I take them? Do I not? How does that discussion go with your patients if they say, no, I am not going to, I'm going to ignore these studies that are done by mainstream, and I'm going to look at these other smaller, clinical studies. Who knows who's running them? Maybe it's a supplement brand or whatever. Where does this conversation go, and how do you help those patients that refuse mainstream medicine?
Sure. So this is a fascinating topic for me because I feel like I sit in the middle and I make everybody unhappy. And this is in part because my nutritional bias is that for most patients, I do believe, especially when they have metabolic disease, that therapeutic carbohydrate reduction is the approach I take most often. It does not work for everybody, and I have learned a lot of humility as I have grown as a practitioner to, come to this idea that what is right for one person is not right for everyone. That said, I would say most of my patients do better with carbohydrate reduction than to proceed with like an Ornish or an Esselstyn-based approach that is very, very low fat, but some do. Some do better with that, and I acknowledge that that's what's in the cardiology literature. And statins are kind of in the same boat, right? There is the classic preventive cardiology dogma right now, which is the lower your LDL-C or ApoB or small dense LDL. We can talk about that someday too, but whichever marker you wish to describe the atherogenic particles, the lower that number is, the better. And there is a whole other cohort of people, and this is very prominent in the low carb community where I have been a part of that community for many years now, and I've heard all of the lectures and I've gone to all of them. There is a huge component that says, look, LDL-C does not predict well the presence or event rate in cardiovascular disease. It's okay, but there are a lot of things that are better predictors, like HDL and triglycerides, which is, again, part of the metabolic syndrome. And so there are many people who believe if we just perfect our metabolic markers and our HDL and our triglycerides are okay, then that LDL-C number or the ApoB number doesn't really matter anymore. And we can ignore that. To which I say, I understand where the data come from. I understand that there are side effects, especially at higher doses of some of the statins, but they're not all equivalent, right? Old statins are not the same as new statins, and dose, I believe, is relevant in terms of things like worsening insulin resistance, right? New incident diabetes at high doses, that can happen with statins. We also have a number of agents to lower those atherogenic particles now. Statins are but one. We also have the PCSK9 inhibitors. We have bempedoic acid. We have ezetimibe. We have a large stable of horses who can help us lower those numbers. And the prevention is different than the treatment of active disease. So there's a lot of conflation of, statins are the same for everybody. Well, no, if you've just had a heart attack or you just had a bypass for critical limb ischemia, you're not the same as somebody who's coming to me in their 40s with no complaints, no symptoms, minimal plaque, but just an elevated LDL-C that's slightly above a national prevention goal. Like I treat those patients incredibly differently. Our goals are super different. So I tend to use, when I can, low-dose statin therapy and adjuncts like ezetimibe or PCSK9 inhibitors in my prevention population if there is presence of plaque, and if I believe that the lipids are contributing to that, while we also address all the other things, right? Inflammation, oxidative stress, metabolic dysfunction, hyperhomocystinemia, all the things, right? LP little a, we can talk about all of that. And I do believe that part of the strategy for managing plaque and preventing progression of plaque over time is addressing the atherogenic particles that do form in the wall. Now, in my surgical practice, where I am seeing people with threatened limbs, I still do follow our guidelines, which say high intensity or maximally tolerated statin therapy and adjuncts to drive LDL-C. And we still use that because that's what the trial data are based on to drive LDL-C below 70, although probably someday that will go down to 55, which is where it is for the coronary population. And for those patients that are in secondary or what I now think of as tertiary prevention, they have plaque and they've had an event like threatened limb, heart attack, stroke. It does seem that the lower the ApoB, LDL-C, small dense LDL, the better in terms of major adverse cardiac events and major adverse limb events. But that's still controversial in other circles. So, like I said, I make everybody unhappy. I don't love statins for everybody. I absolutely acknowledge that there are some side effects that are very real, especially in terms of worsening metabolic function at high doses. And sometimes we have to use them, right? Sometimes in our patients, if their leg is at risk, we'll tolerate that at least for a period of time while we get the fire that's going on in their arteries stabilized and smoldering, and then maybe we can talk about what happens after that. But
Yeah.
I think it's a nuanced conversation. I don't believe, if dyslipidemia or cholesterol was the only thing that drove heart disease, we would have solved this 20 years ago. We've had agents that lower cholesterol for 20 years, and we're pretty good at making the numbers better, but it's still the number one killer. And so there's all this residual risk. And what I like about my practice is that it's my job to figure out what else is going on and try to use sort of the lowest dose of everything that we need to manage all the different risks. And sometimes that is a low dose statin, sometimes it's not. And if a patient says, "Doc, I'm not doing it, don't want to do it," I say, "Okay, that's fine. It's my job to give you options, to educate you, to tell you what I think is the best evidence we have thus far, and we can try something else." My personal anecdote for that is, nattokinase is the one that people do bring up to me. I have seen the study. I was really excited about it for a while. I tried it in my patient who drives most of my care decisions, who's my mom. My mom is the healthiest person I know, but she has terrible arteries on ultrasound, and she's got a dyslipidemia that I don't understand. It doesn't seem to be any of the classic FH mutations, but she and every member of her family, her side of the family, has had elevated atherogenic particles for almost their whole life. And so I tried her on nattokinase for a year, and we had significant progression in her IMT. So I have been not super impressed, at least with my N=1 experiment. But what I also love about the metabolic practice is it's shared decision making, right? My job as a teacher. I'm not your parent. I'm not your spouse. It's not my job to tell you what to do. It's my job to give you information, tell you about risks and benefits, and let you decide what makes sense for you. And many patients choose not to be on statin therapy. It's okay, right? I'm not going to be angry. I'm not going to fire you as a patient, right? It's just my job to help. But I also say, let's recheck. Let's check again in a year or two and look at your arteries and see what's going on. If they look the same, great. We'll keep on doing on. If they look worse, then maybe we should change our plan. But I like to try to just be evidence-based about it. And I think that helps a lot of patients, right? We say, okay, this is a disease process that takes 10 years, 15 years, 20 years, right? We have time. We have the luxury of time if you're coming to me in a preventive setting to wait a year and see what things look like. Try diet for a year, try more exercise, try just treating the high blood pressure or the insulin resistance, get those triglycerides and HDL better, and then let's see. If your arteries look perfect, I'm happy. I'm so happy with that. We don't have to do drugs. If they don't look perfect, if there's worsening plaque, then let's talk about what we can do different.
The one thing that we hear all the time from patients, and we have a question that's coming up, and who says, "Hey, my cholesterol is amazing." What they're talking about, because we hear, "I don't understand why I'm on a statin. I don't understand why I have heart disease. I don't understand why I have peripheral artery disease or carotid artery disease because my cholesterol is normal. Everything looks good." Because they're looking at a basic lipid panel, and I think that the basic lipid panel, in my opinion, and mine's non-clinical, it's just from experience, and with my dad and myself and some of our patients, is it's a little antiquated because you could have a normal basic lipid panel across the board, but then when you dive a little deeper and go into an advanced lipid panel, look at the particle numbers, you discover that it's not just about, while the quantity of bad cholesterol, let's say, is fine, the quality is terrible, and you have a lot more of the small dense LDL particles that when they become oxidized, and correct me if I'm wrong, and when they by free radicals and trans fats and all that stuff, that's when they can eke into the artery wall and push it out. And, all the damage to the artery wall. So your basic lipid panel may be pristine, but it's the quality. And the statins also address that. But that also gives you a better indicator as to, wait a minute, something is damaging the artery walls. What could it be? In this case, the patient was a smoker. She says every bit of her cholesterol is amazing. It had been put up to 80 milligrams of I can never say this.
Atorvastatin.
Thank you. Atorvastatin from 20 milligrams. Also put on blood thinners, additional blood thinners, clopidogrel, Eliquis. Why do you think that is?
That suggests to me that there's probably either there was an intervention like a stent or an angioplasty or a very high risk lesion that they're worried about. Maybe some evidence of prior stroke or prior myocardial infarction or damage to the heart muscle. But those are pretty heavy guns in terms of the blood thinners and the statin therapy. So that sounds like probably there's either an active treatment or a very high risk lesion that we are hoping to prevent any type of permanent damage. And that's the best guess I can make from all of that. But that's what I would guess.
Yeah, I'm wondering in this case if they're just trying to prevent. There was some spasming, it probably seems, in the arteries with smoking when she quit smoking. The temporary CLI, like, ischemia of the foot seemed to go away. And so there might be something with that they're saying, okay, whoa, wait a minute. Let's just max things out and keep things. You've stopped smoking. Let's just maximize your medicine therapy to prevent it from happening again.
Sure could be. Yeah. Hard to know without a deeper dive, but again, I think, people try very, very hard to do the best thing for patients based on our guidelines. To be clear, in the case of secondary prevention, meaning classically defined as somebody who's already had a heart attack, a stroke, TIA, or a limb-threatening event, then we will use statin therapy regardless of your LDL cholesterol. They have reducing that LDL number, again, because it's not the best number, and we know that, but it's usually what we get on a standard lipid panel. So I completely agree. I do advanced lipid testing in most of my patients. There is some value in the standard panel, like triglycerides and HDL, but those are probably the two numbers I take from that. And when I talk about atherogenic particles, I do want more advanced testing to talk about that more specifically. And as we begin to think about those patients who've had an event, we also know that it's kind of the beneficial effects of lipid lowering are partially from the atherogenic particles, but there are also pleiotropic effects. And that means the drug does other things just besides lowering the lipids. So for example, and this is controversial in some circles, but the Jupiter trial was a randomized controlled trial that looked at patients with elevated HSCRP, or high sensitivity C-reactive protein, which is a generalized marker of inflammation in the body. And we know that for people with an elevated HSCRP greater than 3, there is an increased risk for heart attack and stroke. And that's because the inflammation damages the wall of the blood vessel or the endothelium, and the body's repair mechanism is to deposit plaque, right? To seal that over so we don't have major problems in the blood vessel. Your body's just trying to help. But the the statin therapy will reduce hsCRP independent of its lipid lowering effects. And if you get both lipid lowering and hsCRP reduction, you get more benefit than just one or the other. So the statins have pleiotropic effects. They may also have some impact on the clotting or coagulation cascade. There are many different things that they do above and beyond just the lipid lowering. So for all those reasons, it actually doesn't truly matter what your starting LDL-C is on a classic lipid panel if you have had stroke, mini stroke, heart attack, limb-threatening ischemia. We're going to put you on a high-intensity statin, at least in the immediate period following that event, to help with the inflammation and help with all the things that we know contribute to plaque rupture and worsening outcomes.
Okay, we have so many questions coming in right now. Everybody loves you. We have Mike here in the live studio audience. You can see he says his doctor put him on a 20 milligram dose of a statin, and he's read that people with PAD should be on 80 milligrams. Do you think he should talk to his doctor about raising that dosage if he has a 75% narrowing in his thigh, the superficial femoral artery?
That's a great question, Mike. I don't know for sure. It kind of depends on how long that's been there, how symptomatic you are, and how aggressive you want to be with your treatment. Yes, the guidelines for symptomatic PAD are to be on high intensity. And depending on which drug you're on, that may or may not qualify. So 20 of rosuvastatin actually would be high intensity, I believe, but it's not for atorvastatin. 40 or 80 for atorvastatin is what is high intensity. But they may also be looking at your lipid panel and deciding that things have been stable for a while and perhaps they don't want to incur the additional side effects of high intensity statin therapy. And that should be a decision that you and your physician make together based on all the evidence and a complete assessment. So I encourage you to go talk to them. Absolutely. We should always be open to those conversations and thinking about, what are the risks and benefits of both and talking about that and making a decision together.
Yeah, and balancing that risk of
Hmm?
potential diabetes. We've had several patients that have ended up with diabetes. Their doctors have told them they've changed the statin since they've lowered the dosage
Mhm.
because they did end
Yeah.
up with statin-induced diabetes. So that's something to definitely consider. And we have another question that's coming in from YouTube, and then we're going to get to some collateral vessel. We have our collateral nation. We talk about collateral vessel growth and how to do it all the time. So I
Okay,
think you're
great.
going to enjoy some of those questions. But PT 103 has another statin question. What is the best statin for its anti-inflammatory properties?
Rosuvastatin was the one studied in the Jupiter trial. We believe that both rosuvastatin and atorvastatin, those are the two that qualify for high intensity statin therapy, will both achieve that. Generally speaking, no other contraindications like kidney disease, liver disease, things that might change how you make a decision. My go-to is kind of rosuvastatin, but I don't think that we know that there's a significant difference between those two in most people. So I don't feel strongly, but if you can be on the newest generation, which are rosuvastatin or atorvastatin, that is Crestor or Lipitor, then that would be my general recommendation. For people who have had side effects on a statin, they are not all the same. And so I do encourage people who've had myalgia or muscle pain with statin therapy to try lower dose or to try a different type of statin. There are others, and not everybody gets the muscle pain with all of the statins. And so it's common actually to try a couple before we land on one that seems to be well tolerated. The other couple things that can help with the muscle pain are making sure that your vitamin D level is appropriate and making sure that you have an option to supplement with some CoQ10, which can be depleted in the mitochondria as the result of statin therapy. So those are things I offer my patients to consider as we think about initiating statin therapy.
Before we get into a few questions on collaterals, when I say collaterals, you're smiling. So I do too. I get excited about them. For those who are just joining in, they might have peripheral artery disease, even coronary artery disease. What are collateral vessels and why are they so important? And how do you maximize collateral vessel growth?
Absolutely. Collaterals are great. So I talk to my patients about the major construction on a freeway, right? So you're named blood vessels are a freeway, and cars are driving down that road to deliver oxygen down to your feet to get your muscles the blood flow they want to help you walk and run and exercise. And, if there's just a crash suddenly on the freeway and traffic backs up, there's usually not a great system to like go around because everybody wants to get off at the next exit. And then that side road gets really crowded and congested. And it's not really better. Maybe you're moving, but you don't get there any faster, right? But if they start doing a huge, like years long construction project, they're putting in, the tunnel or something, building a subway, then that construction is going for years. And that area where there's a lot of traffic and congestion, everybody starts getting off and using the county roads instead. Well, then the county wises up and says, hey, the freeway's blocked, maybe we should add a lane to the county roads because everybody's taking the county roads. And so over time, now your county roads get bigger and they allow more cars and trucks to flow so you can get around that huge snarl of traffic on the freeway. So that's what collateral vessels are. They're just county roads that are going around the area that's narrowed or blocked. But you have to tell the county to build another lane. And how do you do that? You put pressure on it by using it over and over and over again and proving to them that it's going to be beneficial, right? There's more cars, there's going to be more traffic, there's going to be more business here. It's going to be worth the cost because it's costly to add infrastructure. It's costly to add blood vessels. So you have to prove to your body that it's worth it. And that means challenging the body and providing a stimulus to drive that very energy intensive process. What's that stimulus? It's demanding oxygen. What is the best thing that demands oxygen? Muscles. So using your muscles, like walking, is usually the best way to develop those county roads and those collaterals because you are just asking your body to get that oxygen there and you're doing it over and over and over again until it can't ignore you. The hard part is that that's a lot of work and it's often pretty uncomfortable, especially if that blockage is causing so much traffic that you're not getting oxygen and your muscles are screaming about it, right? Those muscles get really unhappy when they don't get oxygen. They cramp, they burn. It's painful. And I haven't personally experienced it from blood flow blockage, but I exercise and I can appreciate what muscles feel like when they're working really, really hard and not getting enough oxygen. And it hurts. It hurts. I get it. But it's also the signal that drives growth and it drives the formation of those county roads or those collateral networks, and they will save your leg. I mean, they absolutely will. If you can take the time and build that up over months to years, it's very clear when we do angiograms who has built up these collateral networks over years. I mean, it's just so clear. You see all of these little county roads, and none of them have names, but there's hundreds of them, and they go around the blockage and clearly provide an incredible amount of blood flow to the leg that has gotten this patient through years until they get to us.
So here's a question that Heinz has. He's in our live studio audience on collateral vessels. If you have an occluded artery in your thigh, the superficial femoral artery, and your popliteal artery behind the knee, how high in the thigh do the collaterals start to bypass the blockages to get down to the lower leg? I heard this is the best area. If you're going to have a blockage, best area for collateral growth in the legs. I don't know. What do you
Yeah, the
say?
popliteal, isolated popliteal is probably the one we see most commonly because there are the geniculate arteries or the knee arteries that tend to come off right before the area behind the knee, and that can supply a lot. But also the deep femoral artery, which comes off at the level of the groin, also can supply a fair number of collaterals to the thigh and to the lower leg. So the short answer is the collaterals come off above the area of blockage, whether that's just above the area or even up a higher. Your collaterals will begin to form above the area of blockage and start to reconstitute those other arteries below the area of blockage.
And we have a question from Donna. We always get this question. I even think that Marcia, who's in our live studio audience, has had this question before. Do collaterals ever go away? The biggest worry for all of our patients is they're walking now. They're building their collateral vessels. They're decreasing their symptoms in their legs, the cramping in their legs over time as they've built these wonderful side roads around their human superhighway, the arteries. and suddenly they end up with a problem. They end up with the flu for a couple weeks. They end up laid up because of another health issue. Are these collaterals just going to go away?
So without another inciting problem, no, I think that generally speaking, once you build them, they'll probably stay. But what we do see is that occasionally, blood flow through the collaterals is still not the same as normal blood flow, and they're smaller vessels and they can be more vulnerable to progression of the disease or the formation of a clot, right? So you can imagine there's this traffic snarl, and if you get, somebody who misses the exit and creates a little bit more of a snarl, then all of a sudden now that exit to the county road is also blocked. So what we do see is that sometimes people who get really dehydrated, either from the flu or from heat stroke or something, or who, may not have been told they were supposed to be on an aspirin or weren't optimally medically managed, do have another problem, or they have atrial fibrillation and they get another blood clot that showers down to the leg. So there can absolutely be a sudden problem that all of a sudden will decrease your collateral flow. And that can be a real issue for people. I would say, in general, again, use it or lose it, but we don't see collaterals just evaporate. The only other thing I can think of that would potentially eliminate collaterals would be revascularization and reestablishing your inline flow back on the freeway. If those collateral pathways are no longer necessary because the construction project is over and we've reopened 4-lane flow on the freeway, those collateral vessels may atrophy or go away over time because the path of least resistance is now the freeway again. So they may atrophy or become atretic over time for that reason. But under those conditions, you would expect still better feeling in the lower extremity because we've reestablished that inline flow to your foot.
Such as with a bypass graft or even a covered stent that is placed, that I've heard that you do lose, in a sense, the collaterals, or they shrink down, or whatever, however you want to say it. But the thing is that when those do get blocked, yeah, you might have, some sudden increase in pain, but they can be built up over time, right? If that bypass is blocked, or if the covered stent is blocked, it may be possible with a little perseverance, a little to slowly create some new pathways. Not going to be fun,
Right.
but it is possible, right?
Sure. And again, right, we see it's very dependent on the individual patient and why we're doing bypasses or stents or interventions of any kind, right? Pain with walking is definitely a longer game, and that is where we absolutely encourage the walking and the development of collaterals and, avoiding any interventions as long as we possibly can, recognizing that some different anatomies and some different people are just never going to be able to have the level of activity they wish without treatment. So treatment is appropriate under certain conditions, and always want optimal medical management of peripheral risk factors and as much exercise as we can. But we do bypasses sometimes for wounds in the foot, and they don't always stay open. But the goal is to get the wounds to heal, and then, yes, we can still work with exercise to build more collaterals to see if we can prevent a wound from forming again, or to try to prevent cramping or numbness in the foot. I mean, there are lots of scenarios in which, yeah, the bypass or the stent may fail, but we still may have enough collateral flow to get the patient to a place where they're, doing okay from a pain and a symptom standpoint, and they're not having, threat of limb loss.
And you did touch on this, but Sue's watching on YouTube and just wanted you to directly answer this question. Do collateral vessels in particular get blocked too?
Every blood vessel can be subject to plaque formation and blockage. Yeah. The sad reality is that stents, bypasses in the leg, in the heart, anywhere we do that, atherosclerosis, or the formation of plaque in blood vessels, is a systemic disease, and it affects all blood vessels, new ones, old ones, stented ones, bypassed ones. And if we are not really aggressive about this medical management, about our nutrition and our exercise and our sleep and our stress and our inflammation and oxidative stress and our dyslipidemia and our hypertension and our smoking and nicotine exposure, if we still have risk factors for the development of plaque, all of those new blood vessels, the stents, the bypasses, the collaterals, they can all become impacted by the development of plaque. And so that is a reality for sure. And that disease will progress if we are not, very diligent about getting all of those risk factors under control.
You bring up such a good point with that leads into our next question, because one of the issues that I find is I don't care what the procedure. I tell patients, unless you're in an acute situation, you need to have a candid conversation with your doctor on the risk factor and make sure that the risk factors are mitigated, including double checking for blood clots. I find that we've had so many patients on deck for an aortobifemoral bypass, and as I said, in just the past few weeks, where the doctor never even tried endovascular with wires and balloons, but even more than that, they never even checked to see or let the patient know, well, is it atherosclerosis or is it clots? If it's clots, then where are they coming from? Do you have valvular issues? Is your diabetes out of control? Do you have AFib? Do you have an aortic aneurysm that's forming? They just do not do it. And I'm like, oh my God, this is going to lead to a revolving door. Well, Lynn says she has had bilateral iliac stents, which are usually pretty durable, right? We see those lasting for years. Now she not only has those blocked, but also a blockage in the aorta. She's had them all opened up at one point with angioplasty. They blocked it again, and now they want to do a bypass. But my question would be to her, have your doctors checked for clot? Have they mitigated that aspect of it? What's your thought?
Yeah, and we're torn, right? As the vascular surgeon who's on call today, if somebody shows up with a wound in their foot, my first thought is, what's the blood flow problem and what's the urgency of fixing that, right? And if they have acute limb ischemia, even subacute limb ischemia, I definitely want to have some idea about why this all happened. But the first priority is trying to save the legs, right? Save that muscle, preserve function as much as we can. And then, sort of after the fact, then maybe we can figure out what's going on and why, so that hopefully whatever we have done now will stay open. Because really, there's something in it for the surgeon too. It's not just this academic exercise of like, well, why did this happen? But if you don't know why it happened, then your ability to influence your own repair, right? My ability to influence whether my bypass stays open in the future is really dependent on where this came from in the first place and what medications and interventions are we going to use to try and keep these open. And there are absolutely patients who, for all kinds of reasons, whether it's a hypercoagulable disorder, autoimmune disorder, right? Antiphospholipid is one that comes to mind. That's a real nasty actor. There are some people who, even with great repairs, don't have good long-term patency. And we do end up just kicking the can down the road and trying one thing at a time and doing the best we can for as long as we can. And we may never be able to really overcome the body's own process that is driving this. And for some patients, that's the very sad reality. But I absolutely believe in this idea of trying to understand the root cause, right? Trying to understand where it came from, because within that understanding is our ability to try to address it and mitigate it and keep whatever new intervention we've done open.
I just think it's so key to stopping that revolving door once they have procedures, is to just, okay, let's sit down. I mean, if you come back a second time, I mean, what is going on here? Let's just itemize everything and see if we can mitigate those risk factors. And
Yeah.
even if it's not something that is standard, well, let's look beyond that. Let's send them to Dr. Lily Johnston over there in San Diego to get to the bottom of it. Which would be great. And Marcia here, what role does hydration or dehydration? You mentioned that a little earlier. So what role does dehydration play in actual blood flow? I know that when you actually are getting your blood drawn from the veins, they always say make sure you hydrate before you go in, because that can make it easier on the phlebotomist to get to your blood easily.
Yeah, and phlebotomy is about the veins, right? So you'll notice that your veins will get fuller or, flatter depending on your level of hydration. But there's actually a pretty interesting study that came out, and I'm gonna blank on this. I'm sorry, I wasn't quite prepared for this one off the top of my head, but there was a study that came out, I think a few years ago, where somebody tried very aggressive hydration as part of a claudication strategy. And it was actually pretty effective. So it's not standard. Don't get me wrong, like don't start drinking gallons of water a day because some doctor on YouTube said it was a good idea. Get some education, talk to your own doctors about this. But I will say that blood viscosity does seem to be somewhat relevant. It's not something that I address in my patients on a day-to-day basis. So I think in terms of, low-hanging fruit, it's probably not the first 1 to 10 things I talk about. And I think probably the true answer is we don't understand exactly what role hydration plays, but there are some interesting studies and some interesting things that do suggest it might be more important than we thought. And I offer this with a little bit of caution because many of our patients are on diuretics or water pills. Many of our patients have issues with their salts in their blood, like electrolytes. And for you to start drinking a bunch of water or a bunch of electrolyte water. I mean, all has to be done very carefully and cautiously. And I don't want anybody to walk away saying, oh, the doctor on YouTube said we should just go drink gallons of water. But I think there's maybe something more here than we really know. And if you think that it's safe and appropriate in conversation with your team to explore that, great. And I certainly think that for people who have been prone to blood clots in the past, times of dehydration may be increasing risk. So if you find that you have a terrible GI bug for several days and you know you have PAD, do your best to keep those fluids in and stay hydrated if you can. I can't say for sure that that will stop you from having a problem with your leg or your stent, but I do think for people who are vulnerable, dehydration can certainly play a role. And we do see patients who come in after some period of dehydration where there's now an acute vascular event. So I don't have specific recommendations for people in terms of what they should do every day or how to address that on the individual level yet, but it's probably more relevant than we think.
So we just have, do you have a hard stop? Because we have a few more
No,
questions.
I'm
Everyone
okay.
is so excited about you being here. We might have to do this as a regular series because I've never seen a doctor with more questions than we're getting with you. And they're still literally coming in. I'm not even sure we're going to get to all of them, but we're going to try here. Natalie out of South Africa, she is asking what your views are on the carnivore diet because there's a gentleman you can actually search on YouTube who has PAD and he has committed to doing the carnivore diet and says it's actually benefited him. She's been reading a lot of material aside from that, saying that it can help with inflammation, but she's worried that it may increase cholesterol and that she may gain weight. She's wondering if there's a safe way to actually do it, or is there an absolute no altogether?
I love this question because and hi from South Africa. Thanks for joining. And certainly there's a whole contingent in South Africa called the Nutrition Network that may have some more information for you on this. I have done training through them. Prof. Noakes
Oh,
is down there and runs a whole school and program in therapeutic carbohydrate reduction, and carnivore is part of that schema. And so I think it depends on what you're trying to solve, and whether you're excited about it and whether you think it might be something sustainable and possible for you. Just like all of these interventions, there's what works for the whole population and that seems to be irregular. And then there's what you want to do, right? Some people come to me wanting to do an Ornish style or Esselstyn style, which is probably the anti-carnivore diet. And some people come to me on carnivore and say, I am not stopping this for the world. Whatever else it's done to me, you make that better. But like, I'm not stopping this. I feel amazing. My energy is better. My joint inflammation has gone away. My back pain has gone away. I can sleep for the first time in 5 years. Over my dead body, will you take away my steak? And I say, great. There are very few things in this world that make joint inflammation and back pain and sleep and mood and energy so much better. And if the consequence is that we have raised your LDL-C or your ApoB or your small dense particles, then let's see if you have plaque. Let's see if it's a problem. And if it's a problem and you have plaque, we can treat it, right? But there are actually pretty easy drugs to manage dyslipidemia. Not everybody gets an increase in atherogenic particles going on a ketogenic, very low carb, or a carnivore diet, but some do. There is a whole category of lean mass hyperresponders. That's another topic for another day. Um, and so what I think the safest approach is to get an assessment for whether you have plaque already or not and get a baseline. Do it if you want to do it, catalog what gets better, what doesn't get better, and then reevaluate your blood panels and your chemistry and your lipids and reevaluate your arteries, whether that's ultrasound, whether that's a CT angiogram, CAC plus minus on whether that's great for evaluating changes in under a short period of time, but something, right? CAC is better than nothing. Another reevaluation of your artery disease and see if that changes. And then we decide based on the evidence, right? I try not to make these decisions as a blanket statement, like carnivore should be done for everybody. I know some people who feel amazing on it, and I know other people who feel terrible. And if you feel terrible, then don't do it. That's your body being smart and telling you it's probably not right. If you feel amazing on it and there's a small consequence in one system, but 8 other things have gotten better that I can't fix with any drug in the book, then maybe we deal with the one thing that's a side effect because I don't know, nutrition is still like a drug, right? There are risks, there are benefits. There's never anything that's all good, no bad, all bad, no good. We just balance that, right? And we go based on what's happening in your body, how you're feeling, the best of our understanding based on your labs, your imaging, your examination, and we deal with whatever comes up as it comes up. But I can't predict whether you're going to have changes in your lipids that are problematic, whether you have plaque already. If you're here, you may have PAD, and so that's maybe a hint. But maybe it's going to get better, maybe it's going to stabilize. We don't know. So we just have to be empiric about it and gather data and change our plan over time as we get more information. But if you are tempted to try it, do it with some evidence. Get some labs now, then start, see how you feel, see what gets better or not, and then reevaluate, 3 months in, 6 months in, see what's going on, and then make a decision.
You definitely will become very popular with that answer in our network. But being in our groups, a lot of people, we talk so much about natural methods, mainly the walking. We have our collateral nation that meets every single week with tips and tricks on walking as medicine and exercise, et cetera, et cetera. A book you may want to pick up is How to Fight the Crippling Pain of Peripheral Artery Disease by Kevin Morgan,
Okay.
an 82-year-old world triathlon athlete competing at you'd even want to interview him. He is interesting. He's on every Wednesday with us. He has his own exercise regimen. He has 100% blockages going down his legs. He literally has no flow except for collateral flow, according to his doctors at UNC. And he's been able to keep his feet, keep them warm, and compete at the international level at 82 years old with all of his methods. And he has genetic I just can never pronounce these long words, hypolipidemia. I'll just
Okay.
shorten it. Anyway, so you'd be really interested in his methods as well in picking up that book. He also has inspirational self-help books.com, very long URL. Last few questions here. They're in regards to just avoiding doing surgical procedures because we always talk about the walking, we talk about the diet, and so much that patients can do without it. So now we have several people that are here that are saying, hello, we don't want these bypasses. My doctor is offering them. One says from Judy, top of her toes and footer are ice cold, a little red. But as she moves, she actually gets some warmth in them. She's refused bypass. Is that really her only option, or can she double down, you think, maybe on exercise?
It's a little hard to know without seeing the foot, right? So we have to talk about where we are on the spectrum of symptomatic peripheral arterial disease. We go from that claudication or pain with walking, then there's this intermediate, like really short distance claudication, which is almost like rest pain. Then there's ischemic rest pain, which is pain in the classically described as pain in the feet at night with elevation that gets better with dependency or with gravity, bringing those extra 2 or 3 red blood cells down into our toesies and trying to get them perfused at night, all the way to wounds, ulcers, tissue loss, right? And once we get into rest pain and tissue loss, that's when we describe this as limb-threatening ischemia. And obviously, the goal at that point is to prevent limb loss. And I'm imagining that if your surgeon is offering a bypass, they are concerned that you might be in rest pain or have early signs of maybe impending tissue loss. And sometimes those red toes are almost pre-ulcerated, and there can be an appearance of them that is potentially concerning, right, for an impending ulceration or a pressure injury that's not staged, things like that. Can't say for sure. What I will say is that if you're uncomfortable having your operation, get a second opinion and probably don't, or get a third opinion, right? But don't sign up for major high risk surgery, which includes stenting, by the way. I put all of those interventions in the generally high risk category. Don't do that if you're not comfortable with the plan and with your provider. I think every surgeon, interventionalist should feel free to refer people for a second opinion, or a third opinion, right? And not everybody is everybody else's cup of tea. I don't resonate with everyone as a doctor, and that's okay. But you are putting your limb and your life in my hands if you're coming to have a procedure with me. If you have this niggling doubt that like something's not right, it doesn't feel right, you don't understand, you still have questions, if something isn't right, please listen to that. Please find a provider who has taken the time to explain things, who makes you feel like this is the right decision, and so you understand why they're offering this. It sounds like you may not totally get why they're offering this or why they feel so strongly about offering this bypass. I really believe that they are trying to help, and I'm assuming positive intent and that they want to be doing the right thing. But if you don't get that yet, then don't sign up for a procedure until you understand. So maybe it's just you need another appointment to talk to your surgeon. Maybe it's that you want a second opinion. All of those things should be on the table. And if you don't resonate with your surgeon or with the plan, don't let somebody cut on you or poke at you until you feel
Yeah.
good about it, because I suspect you would do fine, right? Most of the time, our patients do well, and most of the time, the outcomes are positive. But if you are among the few but unfortunate patients who has a complication, those are devastating, and you will have a hard time recovering from that mentally and forgiving yourself if you have not, if you didn't feel good about it going in, right? You'll be kicking yourself the whole time, and nobody wants that for you. Like, that's an awful place to be. So before you have anything invasive done, please try to, I mean, nobody wants an operation or a bypass. Nobody wants to be in a position of needing that to be done. But that's different than not feeling comfortable with your plan or not feeling comfortable with your surgeon. Um, I would really encourage you to either go back and ask more questions or get a second opinion so that you can verify that this is the recommendation and feel confident in the plan going forward. So if anything unexpected were to happen, you at least understood why you were there in the first place and that it was really necessary.
And that I think also will answer that was from Judy. And I think Kimmy has the same type. And I think your answer would be the same type 2 diabetic, symptoms in the calf, trouble climbing stairs. At times, she thinks her feet are cold, but when she touches them, they're warm. But they have that cold feeling, inside the limb. Doctor checked pulses. They do seem weak, but she really just doesn't want a procedure. And you made the statement, hey, you know what? The signs that you really do need a procedure: rest pain that wakes you up at night, a wound that's not healing, 100% critical limb ischemia, no ifs, ands, or buts, don't pass go straight to the hospital. And that's where you need to have something done. But again, you still need to feel comfortable with the person doing the procedure and make sure that you do understand all options with different doctors and choose the plan that feels most comfortable for you in those situations. And we have Kate. She has, and I love this question. She has her first appointment with a vascular team to see if she has PAD. So, what are the most important questions she should be asking?
So if you're going to get that evaluation, you'd want to know what imaging have they done. Typically, that would be an ultrasound with an ankle brachial index or a measure of the pressure. Optimally, they would also do like a toe pressure or a transcutaneous oxygen measurement, TCPO2s. Not all labs have that available. Mine, for example, does not yet have that available, but at least an ultrasound and an ankle brachial index is kind of a baseline. That's typically how we will establish the diagnosis of peripheral arterial disease. And ABI or ankle brachial index less than 0.8 is classically the number we'll use to make that. If you have diabetes or renal failure on dialysis, that number can be unreliable, and that's when that toe pressure measurement is very helpful. They will also potentially look and see if there are any areas of narrowing or blockage. They should be able to see that on the ultrasound test as well. Sometimes it comes from a CT scan or other imaging, but ask them what those imaging studies find. Ask them what they see on their physical examination and what they are recommending in terms of medical management, right? Because in general, the first step should be baby aspirin and lipid lowering therapy, like the statin that we talked about. Again, new diagnosis of PAD, we want to try to get that fire that's going on in the arteries under control and try to get that stabilized before we start, tinkering and tweaking medications. So initial recommendation would be aspirin and high intensity statin therapy, especially if you're having symptoms like pain with walking, rest pain, or tissue loss. So get that set first and then ask them, based on where I am on that spectrum, when should we follow up again? What are the signs and symptoms that I need to come in sooner? What would be something that would trigger an emergency room visit, right? What are the things I need to think about so that if there's a problem, we get it treated quickly and expediently?
Two more questions here, and then we'll let you go on your way, and we have to schedule another time for you to come back because we are getting more and more. Heinz, who is in our live studio audience, he has what doctors say was radiation induced artery issues, PAD, in the SFA. He heard that radiation induced carotid blockage would also mean stents. So would stents be warranted for PAD in the SFA as well?
It depends on how extensive the area is that's impacted or that's occluded. Um, all radiation damaged vessels are problematic. And the reason that we would preferentially stent in the carotid is that it's often difficult for us to get up higher to get around it to bypass it. And the risk of nerve injury in the neck is quite high in the irradiated field. So stenting is kind of the um, least evil of many possible evils in the neck, and we don't have as much room to work because it's hard for us to get up high to the carotid artery past the area that's been radiated because the skull is in the way. In the leg, the superficial femoral artery, we can surgically access well above the area and below the area that's been radiated. So it's possible that, especially if the whole SFA is occluded, that's a very long segment. Stents don't work as well in that scenario. Your surgeon may be recommending a bypass for that reason. And as long as they can get to an area above the radiation damage and below the radiation damage, I don't think there's any contraindication to a bypass under those conditions. But again, having not seen your imaging or talked to you, I can't say for sure. But I wouldn't necessarily say it has to be a stent or it has to be a bypass. It's pretty individual, and we have more options in the leg than we do in the neck.
Along those lines, FMD, because it's also, it makes, yeah, I could see you smile. We had a patient with that, ended up with a perforation by a stent. But originally, the doctor, before she got the second opinion, wanted to do a huge axillary bifemoral bypass with having it. And I'm just wondering with FMD, I mean, if a stent just easily perforated, I mean, what a bypass might have done and cutting into the artery with bigger cuts. I don't know. What do you think? Have you dealt
Yeah,
with patients?
FMD is actually a category of several different types of disease of the artery wall, and mostly it's a diagnosis based on imaging, right? The arteries look funny. They have this what we call beaded appearance on imaging, and there can be abnormalities on the inside of the blood vessel wall as well that do lead to areas of narrowing or even small emboli or showering of little platelets. FMD is tricky, right? Sometimes it's a problem, and sometimes it's just something we notice on a CT scan that was done for other reasons. And I don't know for sure in any individual case. I smiled when I heard it because I have a patient I'm thinking of who just came to see me for FMD, and it's totally unclear to me whether that's her problem or whether it's a complete isolated finding that actually has nothing to do with her symptoms. And it's hard to know, right? Because there aren't always narrowed areas with FMD, but there can be like webs, is what people call them, like webs on the inside of the artery that cause narrowing that's sometimes hard to see on a CT scan. And sometimes you have to get an ultrasound on the inside of the blood vessel to take a good look. So FMD is tricky, and I can't really give you a blanket answer for what's right or not. I will say not all territories seem to be equally affected, right? So the
Yeah.
classic beds for FMD are the neck, the carotid circulation, the renal arteries, and the iliac arteries. But an axillary bifemoral bypass, you might not be dealing with visibly damaged vessels. Whether they would have tolerated, whether they would have behaved normally or not, I have no idea. But I'm sorry to
That's really
hear about
scary for the
that
surgeon.
very sad case.
It's a tough decision. I mean, for any surgeon with someone like that, because every presentation is different and you literally do not know until you go in there how the vessels are really going to
Yeah.
react with it. Some people react, some people don't. You said some vessels react, some don't. You just don't know. And then finally here, this is more of a fun one from our producer, Josh. Is your research being indexed by AI? Or how does the new information get updated by the newest tech? We need your information out there.
So, I am not really an academician, right? I don't have a lot of published data on any of this. I would love to start collecting the data in my own patients, and that is forthcoming, I think. But I don't have a lot of my own writing that's out in the world. I will say that the group that has taught me a lot, I don't follow their teachings completely, but there's something called the Bale-Dineen method. Uh, Generated by a physician, Brad Bale, and a nurse practitioner, Amy Doneen. And they focus on heart attack and stroke prevention, not necessarily PAD, but again, systemic disease impacts all vessel beds. And so they have a lot of this information that has been published in book form, and they also have a number of scientific articles that's out in the world. And maybe someday I'll be able to begin writing some of this up and finding an audience. But I have published in the past when I was a resident and in fellowship, and I have a lot of respect for the people who are collecting data and really publishing that. And I feel a little bit like a fraud, right? I read a lot, but I don't have my own patient evidence to bring forward just yet, right? I haven't managed so many patients and have thousands of hours of data to bring to say that this is for sure what works. And again, under those circumstances, I do my best with shared decision making. I say, this is what the studies show. This is what they don't show. Here's what I believe anyway. And you tell me what you think, and we can go from there. But I try to be very intellectually honest about the limits of our data and where I go beyond. A lot of what I do does go beyond, right? Many of these things are not considered fundamental, right? What is fundamental? Aspirin and high intensity statin, and that's about it. But again, if that were all it took, we should have fixed all of this years ago. So I operate under the assumption that there are a lot of things beyond that that are important, and that's where I try to add value. And I still have to acknowledge that the data are not perfect for that. And so, we're doing the best we can with imperfect data. So it's not indexed yet. I don't have, a lot of um, publications to show off anything that I've done. This is me doing my best to figure it out one patient at a time.
But I think we could work together actually to publish something in the journal based on what patients are asking for and what their experiences are, just even across the globe. We have 12,000 patients across the globe in our network. And I think we could find some interesting key points that are going to prove a lot of what you're saying and the interest that the patients have in actually more guidance on the risk factors and mitigating those risk factors that are leading to their vascular and cardiovascular diseases. So
That'd be
happy to
great.
work
Let's do it.
on that. Thank you so much, Dr. Lily Johnston. We appreciate you so much. If people want to learn more about your metabolic practice down there in San Diego, do you have a website they can go to?
The best way to contact me is vascularhealthinstitute.org. That is my personal website, and you can get to me that way. I am also on LinkedIn, Lily Johnston, MD. That's probably the second best way to find me, and Scripps Memorial Hospital in La Jolla. If you want to come through that way, just give us a call and set up a visit.
And you can always call the Global PAD Association's Leg Saver hotline at 1-833-PAD-LEGS. And we're more than happy to get you in touch in any questions you might have to Dr. Lily Johnston. But make sure you do subscribe to our YouTube channel for more great content and interviews like this, youtube.com/.